So I just want you to reflect for a second. Has anybody here ever been a patient? Ever had any procedure, yeah? And when you were the patient, or you came with the problem, imagine if you went into your doctor and you had a very bad pain in your head, and the doctor doesn't listen to you. Starts going on about something totally random that has nothing to do with the fact that you have a pain in your head, and you walk out and you say to yourself, what was I doing there? Imagine you go to see Downton Abbey and you end up in the movie It. And you think to yourself, what am I doing here? I asked for a ticket for Downton Abbey. So it's as sort of as simple as that. That what we want is that people listen and hear us. And when you and I are patients, we are so vulnerable. So we are exactly the same as the people that we take care of. They didn't fall down from Mars and be some sort of aliens. When they don't adhere to the medication, when they don't do the exercise, ask yourself next Monday morning, how many steps did you take every day over the weekend? You may not have taken 10,000. And that happens because we're humans and we're all together. We're all the same. There's nothing special or different. So what I'd like to talk to you about today, if it's okay with you, is to first of all ask ourselves, what do people want from the health service? And by people, I mean us as well as our patients. Ask ourselves, well, why should we listen? Then maybe reflect and say, do we actually listen? And if we do, what's the potential benefit of listening? And then how might we actually achieve it? And so starting with this quote that my colleague Pinar got from me, and she said that patients will never care how much you know until they know how much you care. Because fundamentally, it's actually about trust. So when I go to you to take care of my leg ulcer, I trust, first of all, that you know what you're talking about. And secondly, that you will be able to understand that actually it's the smell, perhaps, that's my biggest challenge with this. Or it's that I actually don't want to wear 4-layer bandaging. I'd much rather wear hosiery and have a shower every day. So imagine if that's what you want, but yet you walk out with 5-layer or 4-layer bandage. So clearly then it's not in keeping with what you actually want. So when we explore what it is that people want from the health service, there was a cross-sectional study done of adult volunteers in 4 different types of settings in Washington, D.C. Coffee shops, metro stops, senior centres and community centres. And of the 51 subjects that they interviewed, 28 were female and 23 were male, with an age range of 20 to 89. And of the 12 themes that they identified from the analysis of the data, the 3 most cited as being critical to their healthcare experiences were having a doctor who listens to them, who is caring and compassionate, and who explains things well. So even for me as a healthcare professional, when I go to my GP and if I have a specific problem, I want that person to pretend I never did nursing. And just to explain in plain, simple English what this problem means for me and what I actually can do to help myself. Because in essence, we don't want to go off to Dr. Google and ask Dr. Google what to do, because Dr. Google doesn't know Zena Moore, whereas hopefully my GP or my nurse knows Zena Moore. So to be able to place things into context. And then in another study in Australia, where there were 20 males and 10 females of mixed ages who participated in a focus group across 4 different hospital sites in Australia. And what they really, really wanted was that their emotional and spiritual needs would be addressed. That when they were going home, that they would be prepared for discharge, so they know what to expect when they get home. That there's communication between all of the staff, so we're all saying the same thing, and that they are included, the person themselves is included in decisions about treatment. That their families are also involved in decision making, and that the staff have communicated with the family. and that they respond to our concerns and our complaints. Because things do go wrong, but we need just to be able to be brave enough to talk to people about when things aren't great. So in terms of a study then by Good, they've identified that positive reported outcomes in terms of patient empowerment, productive engagement in their care, and enhanced health and well-being were associated with being listened to, so I know that you value me, that you give me time, so that you consider this to be important, that you give me information and explanations that I can actually understand, that it's a two-way communication process, that the patient valued professionals' expertise, but they wanted to know, for us to know, that they are knowledgeable too. So who lives with the problem is the patient. And who knows most about how the problem actually affects them is the patient. And the patient sometimes needed to be actively enabled to give the information that they wished to impart. So imagine that you're going in to your boss tomorrow to talk to them about something. And you really are bursting to tell them that you have a problem maybe, that there's something at home that's adversely impacting on your ability to maybe perform 110% at work. And after 2 minutes being there with your boss, boss takes over and starts telling you about something they want you to do. And then you walk out feeling really deflated and your confidence is lowered because it's hard for you to get the message across. Rather than the boss saying to you, is there something that you would like to talk to me about, something that you would like to share with me? And then you would feel, yes, this person is open and ready to listen to me. It doesn't mean that all our problems will be solved. It just means that you will be listened to. So in terms of the health service, people want to be treated holistically, and Guido explained that really eloquently to us. So we don't want to be the fractured neck of femur, the chest pain, the appendicitis. We want to be, for me, a 53, almost 54-year-old woman who has 3 children at home, a husband, works, and happens to have a terrible pain in her tummy. Do you know what I mean? Because suddenly then you're connecting, well, there's a lot more about Zena than just the pain in her tummy. They want recognition and promotion of self-determination. So being presented with options where they exist and enabled to exercise choice where possible. So it's about shared decision making and recognizing that in fact, change involves starting from where the patient is and incorporating an appropriate pace of change. So in terms, when we think about patient education, for example, we sort of tend to deliver a standard type of education. So we have an information leaflet, which I share with you, we talk through it, and off you go. Whereas perhaps I'm not even ready. When you look at the stages of change, maybe I'm in a completely pre-contemplative phase where I don't even understand that I have diabetes or any of the implications that diabetes has for me. Where somebody else might come into you already informed about diabetes and really wants to get into the action phase where they're saying, what can I actually do now to get my blood sugars down? But if we deliver the same education to both of these people, it won't work. So we need to start off with the campaigns like you have, for example, the Legs Matter campaign, where you start to get people to think the information that Julian told us about, that's just totally unacceptable, that I would have a leg ulcer and I don't have a proper assessment. So by having campaigns like the Legs Matter helps people to start to understand what they can expect and what actually is available to them and what is the reality of the situation for them. So it results then in feeling valued or cared for. It enhances our confidence in the services or perhaps in my own ability to do something about myself. It creates enhanced motivation, and fundamentally, if, as Julian tells us, that in the future we will have less and less healthcare professionals, but we will have more and more people with problems, then clearly self-management is going to be a really important concept for us. And unless we value that self-management is something that's realistic, that can actually be achieved, and that we have to kind of maybe move away from the traditional, I do the dressing and you do as I tell you, then we would have greater resilience, and fundamentally individuals, and of which we are those, would have a better health and quality of life. Because fundamentally, for many older people, it's not necessarily the longevity that's fundamentally number one important factor for them. What they are interested in is the quality of the years of their lives. So if you could help me to enhance the quality of my life, then I will feel happier and more satisfied. However, negative reported outcomes in terms of patient empowerment, productive engagement in their care, and enhanced health and well-being were associated with a demonstrable lack of respect shown to patients. So for example, simple thing, and it's not about being a patient. So when I arrived at the hotel last night, or yesterday evening, they told me, your booking has been cancelled. Now, how did that happen? I never contacted them, or CSI Travel never contacted them to cancel it. Now, it's happened to me once before, so I knew, do not panic, Zena. Sure, I could always share with Emer if necessary, because she's a very generous person. But, so I was reassured that I had options. But the gentleman wasn't listening to me. And what I was explaining to him was, don't panic. I understand that it has been cancelled. Do you have a room? And if you do, I'll sort it out when I get back home with RCSI Travel. But he was kind of like automatically on the back foot, and he was being defensive, but it was not necessary. I was kind of totally relaxed. I had options in my pocket. I have my credit card. Bob's your uncle. So do you see how he wasn't treating me with a lack of respect, but he just wasn't listening to me. So I actually wasn't making any fuss at all, but he was a bit nervous. So do you see, we could start off on the wrong point, the two of us, and then the communication falls apart. But imagine if somebody's asking you a question and you just ignore it, or you're just not interested in what they're saying. Or in fact, you're thinking on the scale of 1 to 10, what Zena's asking me now is so minor and kind of apparently irrelevant. But to Zena, it's actually really important. So imagine if that was you, and you have a question and I'm not interested in you. Or that your concerns are ignored, dismissed, or contradicted. Because that is how you feel. So imagine somebody said, well, that's really stupid. Or don't be so silly. How many times have you heard that? But I'm not actually being silly, because actually that's what's bothering me. But if you were able to explain to me, then I wouldn't feel worried about it anymore. Or being excluded from your decision making. So I know you have the campaign of no decision about me without me. But reflect, does that actually really happen? And what happens as a result of this is that it causes distress, loss of trust and confidence, lack of compliance, inappropriate accessing of services, because I'm not doing what I'm supposed to do, because I don't really understand what I'm supposed to do, and then maybe I'm going around the services to try to find somebody who'll just listen to me. And fundamentally then resulting in our poor health and quality of life. So in essence, people, which is you and me, are asking us for a service that really starts and ends with listening to them. And that making sure that we see them as the central part of this whole process. So why should we listen? So here is the mandate for the health service in Ireland, and it's saying that the health service, its principles are accessibility, dignity and respect, that you have the right to expect that you would have a safe and effective service, that there will be communication and information sharing, that there's active participation by you, the individual, in the health service. You have a right to privacy, to improving health, and that the health service will act in such a way as they are demonstrating accountability. So I would bring you to any emergency department in Dublin City right now, and let's walk around as we see these people who are waiting on trolleys and have been there for 3 or 4 days, and let's ask ourselves and ask them about this mandate in the health service. As sure as eggs, they will tell us, I'm exposed here, there's no bathroom properly, there's no shower facility for me, everybody is looking at me, everybody can hear what's happening. And then we reflect on these key tenets. And for you in the NHS, it says that the NHS is there to improve health and well-being, to support us to keeping mentally and physically well, to get better when you're ill, and when we cannot fully recover, to stay as well as we can be until the end of our lives. So the NHS works at the limits of science, bringing the highest levels of human knowledge and skill to save lives and improve health, unless you have a leg ulcer. It touches our lives at times of basic human need, when care and compassion are what matter most. So the health service in Ireland and the health service here are singing off the same hymn sheet, and what we are asking is, does it happen? Because ultimately, listening is likely the most ancient of our healthcare skills. It's a critical component of all aspects of care and is necessary for us to have meaningful interactions with our patients. And when we are listening, we have empathy, which Guido told us about. We might be silent, just letting the person communicate. As Guido said, we are paying attention to both verbal and non-verbal communication. And we are attempting to be non-judgmental and accepting. And I'm sure you have come across really challenging situations where patients and people are making decisions about their own lives which are really not going to be helpful for them. But nonetheless, you have to accept that that person is autonomous and has the right to choose. And so that question then that Trudy asked about stress, how do you manage stress in your own situation? Because you have needs as well that require somebody to listen to you and to help you to work through the situations that you find yourself in. So the process of listening then involves receiving so that you get the stimulus. You select, so you focus on what that stimulus is, and you attach meaning to it. You integrate the message into your frame of reference. So after listening to Julian today, we're all going back to make sure that every single patient with a leg ulcer has a correct assessment. And we know we have the ability to do that. So we judge the merits of the information, so the information is very relevant to us, and then we decide what to do. So there's quite a process happening, and if you think about it, it can be a challenge, can't it? Because think of all this happening in a very short space of time. So active listening is a specific way of hearing what a person says and feels, and then reflecting that information back to the speaker. So words we use like, what I hear you say is this correct? So you're asking them, repeating back and saying, have I interpreted what you're saying to me correctly? And your goal is to listen to the whole person and to provide them with empathic understanding. And if we do this, as we said before, we give people value and dignity. So I am valued, I feel valued when I'm with you, and I feel that you understand me as a human. And that none of us are perfect. We may have a skewed way of thinking of things, but they're our way of thinking of things. So if you want to get the message across to me, then you need to understand, how do I actually think? And you do that all the time. You go into your manager and you know how your manager thinks. If your manager is somebody who only wants 3 points on a page, don't give them 10 points. You know that. So it's the same. So taking time to understand your patients will help you to communicate more effectively. And when you're actively listening, it shows the patient that you care about them. So when you were a patient, you wanted the person. I can remember having my last child, and the student midwife came up, and she came to the room where I was. She tucked me in. She kind of put the blanket in here around my shoulder. She made me feel so safe. I said to myself, I am fine now. Nothing bad is ever going to happen to me so long as she's around. So that small act made me feel really confident about her. And it had nothing to do with delivering babies. It was just this human contact that made me feel so safe. It establishes the trust in the healthcare professional-patient relationship. And also, it lessens your chance of choosing the wrong treatment or making the wrong decision, because you are assuming a state of affairs that aren't actually true. So by taking the time to step back a bit, you may see the situation much more clearly. Like the song says, you need to just step back. So it also increases the chance that you will actually get the right piece of information. So how many times have you come across somebody and you ask them, have you any past medical history? And they'll say, oh yeah, let me think now, yeah, I have high blood pressure. And then they forgot about the diabetes because they're nervous. And all this information is flying around in their head, and they haven't sort of practiced for like an interview. You practice for an interview, and if somebody throws you a question you didn't expect, you're not sure how to answer it. Or if you ask somebody, are you allergic to anything? And how many times have they not told you? So you maybe need to say, are you sure now there's no allergies? You understand what I mean by being allergic? And then, oh yeah, I remember one time. And there you go, you got that pertinent piece of information about the person. And it's important for us to listen to patients and their families, because health happens outside of the examination room. You're with them for a very short period of time. The rest of the time, they're somewhere else. As Guido told us, patients are more than just an illness. And also that patients have valuable insights into their own healthcare experience. Well, do you see, I find it a challenge when I go home and you tell me to go out walking. The nights are getting darker, there's poor lighting on my street, and I'm nervous. So do you see straight away, if you were giving that person therapy for exercise to get the calf pump going, it won't happen. So you might say, okay, I understand that. Here's some things you could do around your home that could increase the number of steps that you're taking, rather than assuming Zena's out there walking around all the time when actually she's not. And no wonder my leg ulcer's not healing then. So we move on then and ask ourselves, well, actually, do we listen? So I really like this cartoon, and it says, I'm the one with the medical degree. I'll determine if your back is troubling you or not. So could you imagine if that was you? But listen, in this study here, looking at eliciting the patient's agenda, a secondary analysis that they did, they identified that doctors only listened to their patients for 11 seconds. Now, can you imagine how well I, as a patient, would have to be able to articulate my symptoms for you to understand what's wrong with me in 11 seconds? And surely we're going to have a problem. And ultimately, it might feel like you're speaking to a brick wall. Now, could you imagine what that would be like? So if I go home to my husband now tomorrow night and I don't listen to him, will it feel like this? And the difference will be, he will say to me, you are not listening to me, Zena. Do you know, until you stop, I'm on the phone or whatever like that, and then I have to stop and say, okay, I'm sorry, I'm listening to you now. Well, it's too late, Zena. So when we look at barriers, though, there are barriers from the viewpoints. This study looked at barriers from the viewpoint of nursing, and then barriers from the viewpoint of the patient. And what I'm trying to show you here is that the barriers are not always the same. So of course we could think about, if I came in here today and I spoke Irish, it would be a major barrier, wouldn't it? Because the only one who'd understand me is Emer and the girl from Sligo who's here. So other than that, maybe, or anybody else of you who've chosen to study Irish, which is an EU language, just so we know. So of course, if I don't speak the same language as you, that's a natural barrier. Maybe culturally, maybe there's issues in terms of me communicating with you from a cultural perspective. But there are other barriers. So the nurse-related barriers, number one there was being overworked. The number one for the patient in relation to the nurse was that the nurse was reluctant to communicate with them. Number two was a shortage of nurses, but from the patient's point of view, lack of understanding of the needs of the patients were what they considered to be important. And then they moved down to being overworked, and that they recognised that the nurse was overworked. And if we look at things like, these are the barriers that doctors across the settings of hospital, primary care, etc., these barriers that they perceived to be a problem in terms of communicating with patients, such as patient receives contradictory information, difficulty communicating with the patient previously attended by another doctor. But when we look at what the patient said, they found that a barrier to communication was that one doctor says one thing and another says something else. So we do know from Julian's work that this incongruence in terms of the delivery of care itself, not just the assessment, but in fact that dressings are being changed randomly, and that you get a hydrocolloid today and you have a hydrogel tomorrow, and that the patient says, well, stand back a bit. There's no consistency in what's going on here. That the doctors feel that patients use other sources. Of course they do. Like if I wanted to know what the name of that actual hooker for the Worcester Warriors were, I had to Google it. Because he wasn't wearing a badge, and I actually didn't know him. But then I appeared really intelligent when I texted my sons and said, he is so-and-so. But I did go to Google to find the information. Of course, that's relevant information. But if I'm coming in to you and I'm saying, well, I would really like to have, hydrotherapy for my wound. And it's totally inappropriate. That is a challenge, of course. Patients find that the doctor's language is far too technical. I find that sometimes, even myself, where I have to sort of say, well, what do you actually mean by that? Because maybe your interpretation or your abbreviation is not something I understand. And of course, the patients find that there are too many patients and little time allotted. And there was a very interesting study that was conducted in the United States where patients who were attending their GP, instead of them paying the GP, what they wanted to say was, my appointment was for 9:30. You saw me at 11 a.m. You owe me 1.5 hours of money because my time is money just the same as is yours. And it's something to think about, because how can it possibly happen if we have far too many people squashed in? You're not going to be able to manage that. Other studies show that barriers to communication are, as you can imagine, time constraints. That may be environmental issues such as noise and privacy. So if there's a lot of noise going on, or if you're standing outside the curtain and I can hear, or you're in a 4 or 6 bedded ward, I can hear exactly what's going on with the patient across from me. That there might be pain and fatigue. So I'm just too exhausted. And I'll just say, okay, go on, but I didn't actually really mean that. I'm just too tired. That I'm absolutely mortified about what I am presenting to you with. This embarrasses me. And Guido outlined, when we're talking to children, how you would never commence an examination without communicating with the child exactly what you're going to do. And if the wound is on the leg, the child doesn't want to take off their trousers, you try and pull the trouser leg up and try and really get to look. Reflect the next time you go to take care of an older person, particularly in the emergency room. And before they blink their eye, they're stripped. Now, did anybody ask them, is it okay, I'm going to maintain your dignity, I'll keep you covered and warm, but we just need to do this in order to be able to examine that. In a blink of an eye, and reflect on it, it happens all the time. And just remember, that in terms of embarrassment and anxiety. That maybe people use a lot of jargon, as I said, or also the values and beliefs that you come with. So pain is always a great example of that, because we often have an assumed sort of like idea on a scale of 1 to 10 what the pain is. So if I said to you, it's like labour, for those of us who have had children, you would say, you poor thing, Zena. But if I said to you, I have an ingrowing toenail, you might not feel so sorry for me. Whereas if you had an ingrowing toenail and tried to put it into your shoe, the whole world will know about it. Or worse again, I came across a situation with my own daughter one time where she was in the emergency room. That's grand. We went back in then after she was triaged, and I happened to glance at her notes, and I saw that the nurse had given her a pain score of 2. She didn't ask her. She never asked her about pain. And I saw a pain score of 2. So is that effective communication? Because what difference does it make? She wasn't in a critical situation, so it's like if her score, she said it was 9, it's her 9. It's okay, do you know what I mean? And we learn that all the time. Who pain is, what the patient says it is, where they say it is, and how bad it is. McCaffrey told us that many years ago, and yet we don't practice that today. And maybe that there's information overload. So that would happen, wouldn't it? Like you go in, you get a fright for what the doctor has told you something, you get a terrible fright, lots of information is given to you, and it's like porridge going around in your head. So maybe you need to back away and then come back again and say, okay, I'm a bit calmer now, I could maybe have a bit more chance of understanding you. I'm going to talk about the elephant in the room here. So do you mind if I strap your phone to my forehead so that I can pretend that you're looking at me when I talk? And there is a lot of interest in the use of mobile phones within the clinical environment. Not so that we can have e-technology or that we can enhance information giving, but more that people are using their phones. So I went to a dermatology appointment one time. It costs €250 in Ireland if you go to a dermatologist. In the middle of the consultation, her phone rang and she answered it. €250. And like she's kind of like a powerful person, so I didn't say anything to her. Where I should have said to her, and there's a phone ringing, I should have said to her, stop, excuse me, please don't use your phone while you're speaking to me. Unless she was going to show me a picture of the dermatological condition and say, like, this is what it is, Zena, or whatever. So, but there's a study that's been done by McBride in 2015, where they found a significant difference between registered nurses self-reported and the observed rates of errors associated with using mobile phones. So there was work performance is affected, that you might miss important clinical information, or that there's a risk of making an error. And ultimately what they're highlighting in this, it's that it's the failure to be present in the moment. So I went to a concert just a couple of weeks ago, and the artist says, please don't use your phone. Just put it down and just listen to me. Like in the good old days. You heard how long I am in nursing. I'm using cream, trying to keep the wrinkles away. Nivea, not creme de la mer. Because I think one of them is 6 of one and half dozen of another. So then if we think about what's the benefit then of listening. So effective listening is important because patient satisfaction has been long tied to the effective listening of physicians and other healthcare practitioners. Yeah. And researchers have investigated the impact of communication breakdowns in medical lawsuits and have found that medical practitioners who are more effective at listening tend to get less lawsuits. And it can bear directly on the quality of care and the therapeutic benefits of the medical encounter. Because information is power, listening to and sharing the information is an obligation of both parties. And the research has revealed about medical error, it becomes an ethical obligation, especially on the part of the healthcare professional. So the story from Kim in this particular work by Kagan et al., she just felt that feeling listened to is just being with interested people in the quietness and not judgmental. It's a freedom to express oneself that flows when the barriers don't occur. And it's uplifting. It sort of creates a freedom for the individual because they feel comfortable. And Jason here is telling the same thing. So then if we think about how can we achieve it, so if you think that everything about the patient speaks to us, so the way they come into the room tells you something about them. How they actually sit. So are they sitting on the edge of the chair? Are they sitting nice and comfortably back in, handbag down, ready to talk? Or are they sort of clutching on nervously? How they speak. Do they speak confidently and clearly? Or are they rushing and nervous? You know what the situation is with them. And then how they respond. So are they hesitant, or are they, saying, oh God, really, I'm feeling, you can see that they're anxious and they're not really understanding what you're saying to them. But what you can do is to indicate that you're listening by saying, oh, okay, yeah, yeah, I see, giving your non-verbal acknowledgements, and then inviting them to tell you more about something. So I'd like to hear more about the pain that you're experiencing, or could you tell me a little bit more about what's happening at home so that I can understand where you're coming from? And then you have ground rules. You shouldn't interrupt. Don't change the subject or move on to something else until you're happy that you've covered it. Don't rehear in your own head. Don't sort of like quiz them. And don't immediately start to teach them or give advice. What you're trying to do first is to hear them. And do, though, however, reflect back to them. This is what I think I heard you say. Am I correct? And just to assess what the patient already knows and wants to know. And as Guido said, keep it slow, be truthful, watch for the reactions, and understand where they're coming from. Because healthcare professionals must be able to define and describe active listening techniques. Assessment of emotionally competent behaviours and active listening techniques can assist us to be engaged in, co-create, and to support relationship development. And realising the true power of the spoken word is vital in all of our assessment processes. So an emotionally competent, active listening environment can be transferred to all patient interactions. And these skills are really, really important because we are pivotal in creating the awareness of engaging in active listening and emotional competent behaviours. And really, our patients expect us to do that because ultimately, the most basic of all human needs is the need to understand and to be understood. And the best way to understand people is to listen to them. Thank you very much.